Hello, everyone. Today we are super close. This is going to show everything, Jennifer. So normally we're like in little boxes, but people are going to see us all. I like your background. It's pretty.
Oh, thanks so much. Yeah. Love colors and patterns. So,
Yes. Well, while people are getting prescriptions, they can also enjoy and
yeah.
be in awe of the pretty colors. So
Oh, it's the goal.
yes. Well, welcome, everyone. Thank you so much for hanging out with us for the next hour. My name is Chris Trondsen. I'm a licensed therapist that treats OCD and related disorders. I also have the honor of being on the board of directors for the International OCD Foundation, and we just love what the IOCDF does. And so if you have found us through these live streams or through anything else, we really appreciate your support. As you may know, next week is OCD Awareness Week. I keep telling everybody that I run into, please head over to the IOCDF's calendar. They have a calendar of events. There's so many events next week to celebrate OCD Awareness Week. It starts and kicks off this Sunday and then runs until next Saturday. So head over to iocdf.org/OCD Week. I want to make sure to get that in right at the beginning. So if you're just joining us, I want you to know that there's some incredible stuff that we got going on all next week. We'll have a live stream next week as well. So we are here every Wednesday at 12 Eastern for Ask the Experts, where we bring on different experts from all over the different fields, researchers, psychiatrists, clinicians, and they answer your questions and offer support. So this is your live stream. You want to make sure whatever platform you're watching us on, we're live streaming on LinkedIn, on X, on Facebook, on YouTube, on iocdf.org, Twitch. So whatever platform you're on, make sure to go into the comments. You can interact with other people, say hi, kind of follow along with this conversation, ask questions. We'd love to hear from you, and just let us know where you're from, where you joining us today, and also who you're here to support. Are you somebody with OCD? Are you a clinician? Are you a researcher, a student, a parent of someone, a kid of somebody with OCD? Just let us know where you're from. Before I introduce our guest today, as always, this live stream is not intended to take over therapy or an emergency room situation. So please, if you are in a crisis, IOCDF right now through these live streams cannot jump in and help you in a crisis situation. I will be giving you resources today, but make sure you head over to 988lifeline.org. You can also dial 988 or 911, go to your local emergency room. And as always, iocdf.org/find-help has an opportunity for you to look through and find clinicians in your area. That's how I found my OCD therapist many years ago. And that way you can find someone who could support you. But I'm excited for today. We're going to be here with you, and thanks for hanging out. So as always, I love having a guest. I love having someone to talk to. And today my guest is Dr. Jennifer Siegel. How are you doing today, Jennifer?
Good. Yeah. Thanks so much for having me. I'm excited to be here.
Yes. Do you like Dr. Siegel? Do you like Jennifer, Jen, Sieg?
Honestly, anything's good. We could just go by Jen if you want right now. But,
I'll just do a different name throughout the process.
Mm-hmm.
Well, let me introduce you to who Dr. Siegel is. So Dr. Jennifer Siegel is a psychiatrist practicing in Southern California. Shout out to Barbara Van Oppen at USC. She asked for the link. She's like, I need to support Jennifer. So shout out to Dr. Van Oppen. So Jennifer has earned her medical degree from the University of Pennsylvania after graduating summa cum laude from Washington University in St. Louis, where she received her bachelor's degree in psychology with minors in graphic design and studio art. She completed her residency training at the University of Southern California at USC, where she served as chief resident of outpatient psychiatry. Dr. Siegel specializes in medication management for OCD, OCD-related disorders, and anxiety spectrum disorders, as well as her training in ERP. She is actively involved in OCD-related research and has presented at the IOCDF's annual conference and at OCD Southern California's conferences and events. Currently, she sees patients in her private practice. Oh, that's right, you're speaking at OCD Southern California.
Yeah.
Yes, OCD SoCal is having a conference, so make sure to head to ocdsocal.org. That's November 15th and 16th. And then I know you presented at IOCDF. I saw you at IOCDF. So there's an annual conference every year the IOCDF hosts that is now hybrid. So make sure to go to iocdf.org/conferences. Currently, she sees patients in her private practice, Jennifer Siegel Psychiatry PC, for medication management and or ERP therapy. She also sees clients at an IOP and PHP at Community West Treatment Center, while continuing to teach medical trainees and complete OCD related research at USC. So basically, you have no free time, is what I'm getting from this.
Yeah, I try to stay busy, I guess.
I know. But
Yeah.
but look, there are a lot of people that need help and you're offering it. So it's great to hear. Before we jump in, what I'd like to let everybody know watching, as you saw, Dr. Siegel and myself are both trained in OCD treatment. So today you can ask medical-based questions, anything around psychiatry, et cetera. Obviously, due to scope of practice, Dr. Siegel will be answering those questions. And then any general OCD and OCD treatment questions, both Dr. Siegel and I can answer those. So before we jump into some pre-submitted questions, some live questions, I always like to kind of get what are you seeing right now in your practice? So obviously what I always kind of ask people is there something that you've been seeing a lot of? Like I know I always run support groups and there's always kind of like these hot topics that seem to come up for everybody. And what we were talking about this week is just literally some of the things that all people with OCD share, even if you don't have the same subtypes. So we were talking about how people with OCD tend to ask a lot of reassurance. They tend to struggle with making decisions, wanting to complete things, over explaining themselves. So we were just kind of having a cool chat. But is there anything that seems to keep coming up into your practice right now, or anything that you're excited about that you want to kind of kick off our discussion in?
Yeah, I think, one of the things that I've been seeing a lot is, people who could really benefit from medications with OCD, but they have a lot of health anxiety and somatic OCD. And of course, it makes it really challenging to start medication when you already have anxiety about medication and sensations in your body. And so I think that, that's something that I've been seeing a lot, and how to sort of navigate being able to support my clients in terms of providing them a lot of information, because I think that they need the information to make informed decisions about whether or not medication is right for them. But at the same time, not feeding into reassurance-seeking compulsions, and being very aligned with their therapist. And so I could talk a little bit more about my approach to that, but I think that that's something I've seen come up quite a bit recently.
Yeah, if you could go a little bit more into that, and then I have a question. Is there anything else you want to add to that?
No, yeah, I can jump a little bit in, or take the question that you had about that too.
Yeah, why don't you jump a little in, and then I'll have a question.
Yeah. So I think, a few things, like if I'm talking to someone that's, very new to medication, hasn't been on medication before, one of the things I like to sort of reframe it as is, there's likely a lot that has been going on that's been pretty uncomfortable to get to the point where you're seeing me. And it sounds like it's probably pretty uncomfortable, the status quo. And so even though there's potential, side effects or whatnot with medication, which we can talk about, it's not just a choice of, should I start medication? It's a choice either way, right? It's a choice to start medication, and it's a choice not to start medication. And both of those come with potential risks. It's not just the potential side effects of that, but it's also, the potential side effects of staying really in this anxious mindset where it might be impacting your relationships. It might be, increasing cortisol in your body, which can have effects, long-term on you as well. So kind of reframing it as is either option is a choice, not just one of them as a choice, can be helpful to sort of take the weight off of that, of being like, should I do it or not? Yeah.
Yeah, no, that's why I always like connecting with different psychiatrists in my area, because this is something I struggle with a lot as a clinician. Is this conversation where a client has maybe tried some medication in the past and had a side effect, and so they jump off it kind of prematurely, assuming that this is going to last forever. And I think a big thing they believe is that it's going to increase with the increase in dosage. And then it's really struggle, because I'll have a client that's telling me like, hey, I can barely get out of bed. I'm having intrusive thoughts pretty much around the clock. I can't even begin to try any CBT or ERP strategies or acts because I'm so overwhelmed. But last time I, took medication, I had some headaches and some dry mouth. And it's hard because I want to validate that experience. Look, I went on medication for my own OCD treatment too before being able to get off of it. But how do you walk through someone who has a lot of fears about the side effects? And first question, and then second question, can you talk a little bit about, like, can side effects go away as somebody stays on it longer and increases the dose?
Yeah, absolutely. I love this question. This is, feeds in perfectly to what we were just talking about. One thing I really love to talk about, if someone is coming to see me and they've had a horrible experience or a bad experience with an SSRI, and I'm suggesting maybe trying a different one, what I love to do is use an analogy actually to like exercise. And so I like to say, all SSRIs may increase the level of serotonin in our body in some way, but they're not all created equal. Just like if you were going to go exercise to kind of get in shape, feel more fit, they all feel very different. So you might, go for a run and absolutely hate it, but that doesn't mean you're necessarily going to hate swimming. You're going to hate playing tennis. And so I kind of break it down in that way where it's like, each type of exercise might have a side effect or different muscles that get sore. You might, if you're lifting weights, your biceps might get sore. If you're swimming, maybe your core is getting sore. And so it's kind of like with SSRIs. Sometimes certain exercises make us feel very activated. If we're running a marathon, we feel this high. If you're doing yoga, you feel really calm. And so kind of in the same way, certain SSRIs like Prozac might make you feel more activated. Certain ones like Paxil might make you feel more calm. And so and then of course, like the duration or the intensity of the exercise plays an impact. Our, genetics play an impact, just like our genetics and metabolism and exercise. And so it makes certain exercises more of a fit than others. So I like to just sort of say, if you started trying one type of exercise and you hated it, you probably wouldn't give up on all exercise altogether. You just have to find the one that fits the best for you and your metabolism and feels good. And so trying to use that analogy, I think, can sometimes help. Yeah. And then there's a few other things that, of course, it really depends on the individual person. If they had a very specific side effect, we can talk about why that was or what that was. And also, I think it's important to note, what was the starting dose that someone started the medication on? Because oftentimes, for example, Zoloft, we say the range is 50 to 200, but I find for a lot of people, especially those that have more somatic issues, if you're starting right at 50 milligrams, that could be a lot for some people. And so I always like to, start it at half the dose, and maybe in certain circumstances, we even go a quarter of the dose. But starting somewhere is starting somewhere, and I think that that's really important.
Yeah, no, I'll never forget. I was watching a talk by Kathy Phillips out of New York, who does a lot of BDD research. And somebody was saying, look, I never can stay on medication because I start on the medication and it's just so many side effects right out the gate. And she's like, what are you starting on? And I forget which medication it was, but yeah, it was like a 50 milligram. And the person asking the question was female. She was much smaller in stature and weight. And so Kathy said, look, like if you started on 50, why not start on 5, at 10, at 15, whatever the smallest that they make the medication, and let's go slow. Let's not try to keep jumping and jumping. And so, it's always reminding people of that. If someone does stay on a medication, let's say they get to that highest dose and they're on it for a while, and the side effects aren't going away, what are some of their options? What are some things that they can do before kind of jumping ship altogether?
Yeah, absolutely. So I think to answer the first part of the question, certain side effects, I think this was from the question earlier. In the beginning, it is very common to have more stomach upset and headaches, and those side effects do tend to go away within the first week or two. The reason that we tend to have a lot of stomach upset in the first week or two is because actually 90% of our serotonin receptors are actually in our gut. So it takes some time for our body to sort of adjust to that as well. And so what I like to tell people is, if you can try to stick it out for at least a week or two, usually those stomach upset type side effects can go away. If it's other types of side effects, it really depends on what it is. Sometimes people will have, like sexual side effects. And in that case, there's different adjunct medicines that you can use, like low dose Wellbutrin or Buspar, some other medications that you can sort of add as an adjunct that sort of offset some of those things. But it really depends. It might be that, this medication, even if it's beneficial in some way, it's always a conversation of, are the risks and side effects intolerable enough where you're not able to really appreciate the benefits? And if that's the case, we can always try a different medication and take things from there.
Yeah, I'm gonna set this question. I just sent it to Rachel so she could put up on the screen, but I'm gonna kind of like generalize it because I think this is a question I already kind of pre-planned, and I was like, oh, somebody already kind of submitted this
Yeah.
question. And if you're watching now, you can totally submit questions. Just put in the chat. But this was a pre-submitted question. They specifically asked, "What are your views on medication for those diagnosed with PTSD and OCD? Some medications are approved for one condition and contra." Indicated for the other. How do we avoid that medication Russian roulette? But maybe to generalize it, this is what I hear a lot of times is, somebody has bipolar and OCD, or maybe ADHD and OCD, and the ADHD medicine might be, helping in some ways, but not, or PTSD and OCD. How does someone balance their medication if they are dealing with co-occurring conditions?
Yeah, I think that's a great question. I think the first thing I would do is in the assessment really try to tease apart which of those symptoms, and they could be both, are sort of at the foreplay currently. Um, Oftentimes, with OCD and PTSD in the example, there are medications like the SSRIs, for example, can treat both. So if there is a way to kind of target both of the symptoms with one medication, that's always great. But I think, a lot of the question is what do you do when there's overlap between ADHD and OCD, which we see a lot, of course. And so one of the things is that as we know, that the best treatment for ADHD are stimulant medications, but stimulants are going to make someone anxious most of the time. And so that can also like make OCD a little bit worse. And so I think the first question I always ask myself is, one, I want to really make sure that we have the right diagnosis first. And where did the ADHD diagnosis come from? Because sometimes, depending on how it was diagnosed, we might see that, well, OCD, as we know, is often very much misdiagnosed, and it's the delay to diagnosis is 10 plus years on average. And so I just always want to make sure, is the ADHD, is it really just anxiety or OCD? And is this something that could get better with that? And that's not always the case. But if it is co-occurring, I try to tend to start with treating some of the OCD symptoms first and using non-stimulant options if possible, and just sort of kind of tailor things from there. But I think it really, in those circumstances, it's really kind of the art of medicine, and it's very different for each individual person, and kind of seeing what are their specific concerns, what are the side effects, and kind of taking things from there.
How do people hang in there? How do people kind of, I think that would help, a lot of people watching, like, how do they hang in there as they're like trying different medications? This medication's kind of working, this one isn't. I'm having this side effect, so I have to go on that. Like, what is a way for people to have that mindset where it's like, hey, hang in there, it is going to be worth it eventually?
Yeah, that's really, I think, one of the hardest things when prescribing medications, especially for OCD or anxiety, because the gold standard medications just take time to work. And if we don't get it right on the first try, then it could really be several months before seeing a good benefit at the right medication dose, and that can be really challenging. With that, I try to use analogies at times, as much as I can. So the one I really like is sort of this analogy of like growing a garden. And so, when you first start planting the seeds, you're not really seeing any flowers, you're not seeing anything right away. Maybe even in the beginning, there's like weeds growing and like animals start eating the crop, and you get these side effects and everything kind of sucks. But with time and maybe putting some nets up, or the weather gets better or whatnot, the flowers eventually start to bloom, and then you have this full garden. It just takes some time. And so sometimes that can sort of, help with things. Other things I like to do is, while we're waiting for a medication to take, like an SSRI, to take its full effect, there are certainly as needed medications that you can use to help with anxiety in the meantime, for that breakthrough anxiety. And then also just really making sure, if the OCD is, moderate, severe, even mild, of course, like, are they in therapy? Are they doing other things at the same time that can help as well?
I like what you said about immediate medications. Obviously, like, I get a little nervous if I have a client come in and say, "Look, I've been on Ativan for 10 years," or like, I don't take an SSRI, I only take a benzodiazepine or something. But what I do think helps people is what you said, and I'll talk to clients about that. Have you talked to your psychiatrist and just said, "Look, like, an SSRI takes long. That's why I'm like, I can't wait till they develop super SSRIs where
Yeah.
it's like you take it and it works like Advil or something, right?
Yeah. Yeah.
But until then, it's like, okay, let's start with this medication, maybe to give you just that relief in the immediate as the
Mhm.
SSRI is working, as you're working with a clinician that really specializes in frontline treatments for OCD, and then maybe that can help get you through. So I'm glad that you mentioned that, because sometimes I think people only read SSRIs, and then yes, that's one of the hardest things, is kind of hanging in there and
Mhm.
waiting for it to kick in.
Yeah, yeah, definitely. And there's also, other options out there that are not benzos. I know there's, concern. I don't love starting benzos if I don't have to, and sort of long-term effects of that. But yeah, even things like an as needed hydroxyzine or gabapentin or propranolol, sort of depending on the person and how their anxiety manifests, could be something. And it's kind of nice in a way too. I find that if I have a client that's using these as needed meds for breakthrough anxiety, as time goes on, while the SSRI is starting to take effect, I'll ask them, like, how often did you use your as needed med this week? How often did you use it this week? And over time, you'll start to see that they're using it less and less. And so I'll be like, well, see, like, it's not always like this night and day thing with SSRIs where suddenly you wake up and things are, it's like you're a different person. It's this gradual process where you start to look back and say, like, oh, that would have bothered me. It's not bothering me as much as it was before. And you're starting to realize you're using less of these as needed medications, you're doing more, and it's this like really nice sort of process that sort of unfolds. Yeah.
There was a question from Lisa at 12:15 Rachel's time. I always have to do East Coast. You're on the West Coast with me, which
Yes,
I
I
love. So,
am.
the morning where, but I always have to do it 3 hours different. She says, my son currently takes 200 milligrams of sertraline and has for years. What might be a good addition to that, as he is still having daily panic attacks and period of panic? So let's say somebody is on like a high dose of a SSRI. Can they go up on the dose? Is there adjunctives? Like what could maybe Lisa son approach the psychiatrist to
Yeah.
ask about?
Yeah, that's a great question. So, the first thing is thinking about in terms of OCD and the Zoloft. So, if there is some benefit at 200 milligrams, but there's still ongoing OCD symptoms, and it sounds like maybe some panic symptoms as well. Technically, yes, the FDA has approved Zoloft for between 50 to 100 milligrams, but it is not uncommon to have individuals on doses between like 200 and maybe even up to 400 milligrams of Zoloft. Is very common actually in OCD, and there is greater benefit at the higher doses. And that's more specific for OCD than for, depression or something else, of course. But what I find is if someone is not specially trained in OCD medication management, they might be a little nervous to go above the 200 milligrams. And it's not just on Zoloft, it's really for any of these SSRIs. There's the FDA approved max, and then there's the typical OCD used max. And so one, I would kind of inquire about that. If they're tolerating the medication well, they're getting some benefit, and there could be more benefit, then certainly going up on that. Another thing that could be done is, if the panic attacks are not that frequent and they're sort of, as needed, things like, an as needed hydroxyzine or something now and then. But what I find is if someone is really using PRN as needed medications often, then that's a sign to me that the kind of the medication, the everyday medication isn't enough, because we really shouldn't be using these as needed meds every day. And if we are, it means that we should adjust things. The other thing that can be done, and it really depends again on the individual person, is maybe it's harder to go up on the Zoloft a little bit, but they're getting some benefit. There's of course data for adding like low dose. This is more for OCD, not necessarily panic, but low dose Abilify or something like that to sort of as an adjunct to the SSRI to boost things a little bit. So there's a lot of different things that can be done, but I would probably start by inquiring about going up on the Zoloft dose in that case.
Thanks. Chris on YouTube at 1220 asks, my prescriber suggests taking an SNRI as an adjunct or addition to my SSRI. Do you suggest taking that type of medication for OCD and anxiety?
Great. That's a great question. So Well, first I would want to know, what the rationale and the reasoning is for adding an SNRI as an adjunct, because that is really not standard or part of the typical guidelines for OCD specific treatment. And depending on the dose, I would want to make sure, we're not getting into this area of, increasing our risk for serotonin syndrome, which can happen when you're on multiple serotonergic meds at the same time. I would say in the guidelines of things, there isn't a whole lot of evidence for SNRIs as sort of a first line option. And so first I would sort of ask myself, is there a different reason an SNRI is certainly is being recommended? Is it because someone has like chronic pain symptoms and then they can help with naturopathic pain and anxiety or something like that? But I think what I would do is sort of take a step back and think what the reasoning is of adding an SNRI. And there's probably other things out there that are more recommended and evidence-based for OCD specifically. But of course, I know I don't know someone's individual situation, so there could be a reason for that. But I would say that's certainly not as common.
I missed the first part of Chris's question. So he said, I take an SSRI, Lexapro at 30 milligrams, and an antipsychotic Invega Trinza injection at 410 milligrams. What do you think would be the right amount of those medications for treating OCD? We didn't really talk about it yet, but I think one thing a lot of people struggle with is the medications do need to be at different dosages for OCD. So can you talk on that for a second and then maybe kind of guide Chris's question?
Yeah. So, exactly. So with all the SSRIs, there's like the FDA approved dose ranges. And then there's the typical doses for OCD specifically. And what we find is that really with all the SSRIs, you really do need higher than FDA recommended doses for certain individuals. It's not, some people don't need to go as high, but if they do, it's totally fine as long as you're tolerating the medication well and things along those lines. So for this individual that mentioned being on Lexapro 30, so typically we see the FDA doses of the usual target doses being 20 milligrams. So once you're going above 20, you do tend to get some prescribers, if they're not as familiar with OCD, being a little bit more nervous to prescribe above that. And with Lexapro and more so Celexa, once you go higher, I've had some issues sometimes with pharmacies being unwilling to fill it unless I got an EKG first, just specifically for those two meds. But in this case, so this particular person is on, it sounds like an SSRI and also an injection. It's tough. I would say, the first thing based on that regimen that I'm thinking is typically those types of injections wouldn't be prescribed primarily for OCD. So is there something else going on? Or was the OCD misdiagnosed as something else to be put on that medication? Or is it a combination of things? I would ask, is the Lexapro 30 not working well? Is it working well? And if it's not working and we're thinking of adding like an SNRI on top of that, I would start to get concerned about, especially being at a pretty high dose of Lexapro, adding on another serotonergic medication. So I would maybe think about switching from Lexapro to a different SSRI. But again, I don't know anyone's individual situation, so it's not my medical advice without looking things over. But those are some of the things that I start to wonder about.
No, I think it's good for people. I always think what's best for people to do is, the medication. Like I know for me, when I took Prozac for my medication, and I know for me, like what I was told the medication would do, it was helpful to know, because then I could tell the psychiatrist, yes, this is kind of doing what it needs to do, or like, no, I don't think this is doing what it needs to do. So Dr. Jamie Fusner was my psychiatrist when I was on medication. What he said to me, he's like, what's going to start to happen is you're going to notice that there's a little bit of slowness in the intrusive thoughts. It's not going to be so like quick and then you act. There's going to be like more of an observational component. It'll feel like someone's turned the volume down a little bit and the pacing slows down somewhat. and you won't feel as overwhelmed all the time. And the stuff that may have been feeling like a barrier during your ERP treatment, and I did
Mhm.
ACT and some other, CBT and stuff as well, but you'll be able to sort of do it and it won't feel like it took everything out of you.
Yeah.
But it's not going to just mean that you wake up tomorrow and all your thoughts and your feelings are gone. And so I think because I had realistic expectations, and what I tell my clients is like, are you getting that relief? And if the answer is no, that's really when you want to talk to the psychiatrist that you're seeing and say, hey, based on what I've been hearing in the field, I'm not really getting that. But I also tell clients medication isn't magic, right? Like you could take the medication, but if you're compulsing all day or sitting at home, you're not letting the medication shine. It really has to be in conjunction with you doing the work. But you should absolutely get some relief and it should feel easier. So I always think that's a good guide to ask a psychiatrist
Yeah.
if you're not feeling that experience.
Yeah, I think that's so important, and I love what you said about, medication isn't magic in itself, and oftentimes, if you're at the place where you're needing medication, it's probably most likely that you really need to be engaging in the ERP, and without those are really, designed to be in tandem with each other, and they can really be beneficial when we're working together in that area. So I think that's really important.
Yeah. Rich asked a really good question on YouTube that I'm going to turn into like a bigger question.
Yeah.
Rich said, ERP and faith played a major role in my recovery. However, I found fluoxetine with a low dose of risperidone was a game changer for me. I'm doing well now. I want to come off meds, but I'm terrified I'll return. That was at 12:09 on YouTube. So what I want to ask is that's what I hear from a lot of people. I went off my medication and things didn't return, but I know that that's a big fear of, hey, I'm
Mhm.
doing great. I'm on my medication. I'm afraid though that if I go down or off, things will return. How do people sort of manage that? How do people ensure? Um, how do they know, like, hey, maybe it's time to go down? How do they know it's not going to all come back?
Yeah, that's a great question, and that's also one of the main things is we don't know, and sort of sitting with that uncertainty in the OCD world. But I think the one of the things I think about is, is this someone, it's one of their first times being on medication, they've been on it for, at least a year or two is what we really recommend for OCD, and they're getting this relief. It's totally reasonable to want to start tapering off of it, and thinking about doing that. One thing I always ask though is, what are some of the reasonings or interest in coming off, because everyone has sort of different reasons. And one thing we can talk about, I can put a pin in it for now, but I often hear things of, well, I want to come off because I'm scared I'm going to be addicted to it. And so we can talk about that too. I know that I'm going on a tangent a little bit, but I love that question and answering that question. But yeah, I think if someone is thinking about coming off and they've tried it before, and the symptoms do come back, and then they're going on meds again and they get better, and then they come off and the symptoms come back again. It's totally reasonable to just, it might be in that situation something like, well, maybe this is more of a longer term thing. And if someone is worried about that, that's kind of when I ask, well, what are some of the concerns you have about that? Because I do, there is sort of this difference that I find of being on certain medications longer term, like SSRIs, where understandably, I know there's a lot that kind of is at play when we're thinking about mental health, but we don't always have some of those same inquiries, about things like antihypertensives or cholesterol medication and things like that. So I kind of like to always understand where people are coming from, and if there's certain fears about it, trying to answer those as well.
I know worked for me is Dr. Funinger said, hey, after about a year of
Hmm.
minimal symptoms, not cured,
Yeah.
that's not that I don't want people to hear that, but just like you don't really feel like OCD is taking over your life and you have a good hold
Hmm.
on it, let's taper down very slowly. And if you start to see symptoms rush back, maybe it's premature. But we went very slow. And
Hmm.
because I was doing well, I was out of the house, I was working, I was volunteering, I had friends, I was dating. I was doing ERP at work because there were so many triggers at work. I didn't feel a difference going down,
Yeah.
going off, and then staying off. Right.
Mhm.
So I always tell my clients, I'm like, I think because I did it that way is one of the reasons why I haven't relapsed and had to go back on medication. Not that that's a judgment or bad. I just know that a lot of times people get off of it prematurely.
Yeah.
And
Yeah.
then because they get off of it prematurely, some of the symptoms start to come back. So I think it's really, I tell clients when they ask me that question, I say, okay, when you and I are barely seeing each other, maybe it's 1 month check-ins and you're doing great and you're happy and things are going great. The other thing I tell clients to do, I don't know if it's helpful for you. I hope so. I tell my clients
Yeah.
to do this for their psychiatrist. I always tell my clients like track, just kind of track like
Mhm.
week to week. Cause a lot of times, a client will come in to see you on a really bad day and they're like, it's horrible, even though a week ago they were fine or vice versa. So
Yeah, yeah. I think that's such an important point, and that's something that comes up a lot. Is maybe after a few months, someone is feeling a lot better, and then want to come off. And I totally get that. I do try. Yeah, want to make sure it's not too premature. We do like to say at least like a year or two at a really good dose, and then but when we come off, going very slowly, like you said, is super important. Not only for potential relapse of OCD symptoms, but also to minimize any risk of withdrawal from the medication too, or side effects in that way. But yeah, I think super important. Um, yeah.
I have a medication question in a second, but I wanted to answer this because I know I mentioned it.
Yeah.
Freedom, which is such a cool name, from Facebook at 1209 said, "Is over explaining considered a compulsion?" So it's funny, Dr. Siegel, Jen, I had been talking to my clients forever. I was like, there are certain, because I think in support groups and stuff, clients are like, well, I can't relate because I don't have harm, or I can't relate because I don't have this. But I tell people all the time, there's a string of things that
Mhm.
we all do with OCD that we can relate to. And so I wish I could give credit. I forget the clinician, but a clinician read my mind because I've been creating a list, and some clinician put up on Instagram all the things people with OCD do. And it was all of mine except one. So I added my own slide. But
Yeah.
when we were talking about this idea of over explaining, everybody was like, me, I've gotten feedback on that. And so, yeah, freedom, I think it goes back to what Liz McInville always says, what is kind of the function of behavior. So if you're over explaining because you have to say things just right, or you're worried that the other person won't fully understand and then they'll make an error. So maybe that's at a pharmacy or a doctor. So you're over explaining. It could be because you feel like if you don't say everything, you're going to forget what you're saying. So if there is something behind it, it might be a compulsion. And I tell people the way that you can always tell if it is or not, try under explaining things, and waiting for the other person to ask for clarifying questions and stuff. And if you feel just utmost angst, tight chest, and heart race, it's probably a compulsion. So, but yeah, some of the clients were like, yep, I do that. Malcolm at 1209, 1208 rather, on YouTube says, is there any medication for disgust contamination OCD? I suffer from severe disgust themed contamination OCD, and I feel mostly disgust, not anxiety. So far, only Abilify has helped. Is there anything else that I should try?
Yeah, yeah, great question. So, I think I love that you wrote it that way in terms of I suffer from this, not anxiety, because I think that for a lot of different people, it's sometimes we can think of anxiety and OCD along a spectrum, but sometimes we can think of it as like they are separate, and because they're separate, we do manage them in different ways, and the dosing and the recommendations are not exactly the same. Um, but at the same time, a lot of the medications are similar. It's just sort of the dosing and the duration and how we approach the medications. And so, I would still consider, even for OCD, even if we're not feeling like generalized anxiety, SSRIs are really the gold standard. And so if someone hasn't tried that yet, I would certainly recommend that. And usually for OCD, when we think about Abilify, we're thinking about it as an adjunct for an SSRI, not necessarily Abilify as a standalone medication. And so that's kind of what I would think about there.
Yeah, I'm gonna send to Rachel to put in the chat. But there is a book by someone by the name of Rich Gallagher. I'm a little bit biased because I wrote the foreword to the book, but he really is the only person that has written a book that really specifically I'm putting it in the chat, but I think it only goes to YouTube when I do that. So I'm going to give this to Rachel, so maybe she can put it in the chat to all the different platforms we're on. But I know I know for a lot of people that have more of that disgust base, some of the traditional parts of ERP doesn't always work, because if nobody really likes let's say it's a lot of times it's bodily fluid, so nobody really likes feces, right? So having a client sit there and like touch a toilet over and over, nobody's ever going to be like, yay, I'm habituated to feces. So there's a little bit of a slight twist on how ERP is implemented. So Rich Gallagher, I know, has written some stuff for the IOCDF. He has a book, so hopefully that'll be helpful, Malcolm, as well. Freedom says, yes, I'll try under explaining. Great idea. Yeah, Freedom, think of it like this, is like, let's say you're going to explain it. Trust that if the other person doesn't understand, they'll ask clarifying questions, or if their response to you is so off what you said, then you could clarify. So I don't know, Jennifer, if you've ever thought of this, but having OCD, my brain always tries to come up with stuff. And I was like, what do people with OCD and not OCD do different? People without OCD wait for an incident first, and then they respond. So what I mean by that is, Freedom, if you're talking to someone and they're like, huh? Wait, what? That doesn't make sense. Or you ask them something and their response is way off, then they'll reply with some more explanation, right? But for us, we already premature decide that like they're not going to understand fully, or I'm going to insult them if I don't over explain why I didn't pick them up from the airport, right? We're already assuming something's going to go wrong, so we react to it, but it hasn't happened yet. So that's why that could help for sure.
Yeah, and I would also I think that's a great explanation. And to add to that too, I also, like many of us, have OCD, and so I find myself over explaining a lot. And one thing I have to think about is, am I over explaining as like a form of more like covert reassurance seeking? So I might not be asking a question, but I'm sort of like making these statements, waiting for someone to just like support it or reject it, in this like kind of sneaky reassurance seeking type of way. So that's another thing to think about too.
Yeah, I always tell people too, is what you're doing for you or for the other person? So if I'm not over explaining, but if I'm, adding more explanation because the other person needs it, they've told me like, wait, I don't get it, then I'm doing it for them. If I'm like, I need to keep going and say this because if not, I'll feel anxious, then it's for me. And so if it's more for you, it's usually OCD. I like this question. So Stella asks at 12:38 on YouTube, I've been improving and I am now struggling with intrusive thoughts about having intrusive thoughts. Is this kind of a meta worry? Is this kind of meta worry common? So I'll take a little bit and then I'll toss it to you, Jen, to add. Absolutely, Stella. So a lot of times people start to have thoughts about thoughts they may have, right? And so people are doing well and they're improving and they're like, I don't want to have any more OCD. I'm doing great. Everything's good. And then they start scanning. And obviously, physical scanning is a compulsion, but mental scanning could be as well. And it's like, I don't want to have an intrusive thought today. I'm going to go see my niece and I have harm thoughts around her. Like, I'm worried I'm going to have thoughts and I don't want to have these thoughts because I'm going to get better and I need to get better. And then pretty soon you're already prematurely worrying about the thoughts, which are now creating new thoughts. And so one of the core aspects of facing our OCD and anxiety that I love is we teach ourselves that thoughts can't harm us, right? They're uncomfortable. Trust me, I have OCD, so I know it's not fun. I'm not dismissing your experience. I'm just saying, like, when we show any kind of like fear, resistance, worry about having thoughts or having feelings, they're going to be 10 times as loud and they're going to be 10 times as intense. So if you are literally saying, I'm going to go here today and I probably will have thoughts, and now OCD is having me have thoughts about having those thoughts, cool. The more thoughts I have, the more I get to practice the treatment, the more I get to overcome it. And pretty soon I will be laughing at these thoughts versus being overwhelmed. I don't know if you feel like I missed anything, but I just wanted her to know it's common.
Yeah, I completely agree. I echo exactly what you said. I think that's a great answer. Yeah.
Yeah. Mohammed asked on YouTube, what do you say about avoidance? Like avoidance for OCD, or this person was saying phone addiction. I always tell people there's 5 big things I see clients do to avoid their thoughts and feelings. It's oversleeping, so naps during the day, oversleeping. It's alcohol, it's drugs, it's scanning, or scrolling, not scanning, sorry, scrolling their phones, or kind of like bed melting, just like sitting there like on their bed watching Netflix for hours. Like those are usually avoidant because it doesn't really take anything from you. So yes, phone addiction and avoiding on your phone can absolutely be an avoidance mechanism. But why does avoidance not help for OCD? Because I think sometimes in non-OCD, if you'll see like a kid not like something and the parents like, that's fine, you don't have to eat it, or oh, you don't want to go there because you don't really like it, don't go. But for us, we're like, do it.
Yeah.
Yeah. What do you say when a client asks you like, why is avoidance bad for OCD?
Yeah, for sure. So in terms of it really does reinforce a lot of the compulsions, and so with avoidance, it's you're sort of laying down the structure of telling yourself like there is this fear with this, and sort of just continuing to reinforce. When you avoid something, you're sort of giving more credence to that thing, and also the like really telling your brain and feeding into this circuit of you have these intrusive thoughts, you have these fears, you might temporarily avoid things, and maybe in the short term there's some sort of relief with it, but in the long term it's just sort of reinforcing those patterns and becomes harder and harder to engage with those things. And so in OCD, yeah, we really do want to make ourselves feel a little bit anxious and learn that we can tolerate that anxiety and tolerate that uncertainty. And that sort of really helps us keep going with what getting into things that we were initially avoiding. Yeah.
You know what? That reminds me, Jen. I'm not going to have the timestamp for Rachel, unfortunately, because there's so many questions and it was back.
Yeah.
But somebody had asked, they had said like, I'm really nervous about ERP. Like, I don't want to do these things that kind of make me feel like I'm going to be put down or humiliated or uncomfortable. What I always tell clients is like, I wish, I can't because of HIPAA, but I wish like I do IOPs for intense clients. And I wish somebody could follow us with a camera to show people what ERP really is.
Yeah.
I'm surrounded by like a large mall here in Orange County, South Coast Plaza. I'm by the beach, etc. And I really ask clients, I'm like, hey, if you didn't have OCD today, what are some things you'd want to try? And so let's say somebody has harm OCD, right? And yay, Rachel found it. Thank you, Rachel. People will say to me like, well, I would love to eat, at a restaurant, but I'm afraid of like harming people in a crowded area. Or I would love to go to the mall because I'm afraid I'm going to blurt something out. Or I'd like to play basketball at the park. But I'm worried, that I'm going to miss the shots. And if I miss a shot, I get a bad thought that something's going to happen. And when they're ready, and obviously we work up to it, I'm like, let's go play basketball. Let's go to a restaurant. Let's go to the mall. Right. So I have to do the treatment with a client, right? I don't want to be licking toilets. I don't want to be like yelling slurs at people as they drive by, right? It doesn't have to be done that way. There's some really good work by different people like Lauren Wadsworth and Caitlin Pinciotti and stuff about like justice-based ERP, where you can do ERP in a way that doesn't humiliate you or feel embarrassed, etc. Not going to say it's not going to be challenging. That's going to be there, but the work doesn't have to be humiliating or uncomfortable. And remember, treatment is collaborative, and you always have a voice, and your clinician should want to hear from you. And if you're ever in a situation with a psychiatrist or a licensed therapist, and you feel like your words aren't even being listened to, then that might be a sign that you speak up or find someone else.
Yeah, absolutely. 100%. I think, I love what you said about, in terms of doing ERP and exposures, there's so many ways that you can do it. And that's part of, what I love about it. There's a lot of creativity and an art to it. And, there's a lot of different ways we can approach it to, make it so that it's still increasing in anxiety, which is sort of the goal, but it doesn't have to be something like we're licking toilets or, licking the bottom of a shoe or something that no one is really wants to do.
Exactly. I'm not into that. I was very fortunate. I mean, my therapist was a little ahead of her time. Shout out to Karen Pickett, but all of the stuff that I did with her were things that I love doing now. There wasn't really something that I did and I was like, regret it all these years later. Like, how come we had to do this to get better? I know for me, I had pretty intrusive harm thoughts around my grandma, my youngest sister, when I lived there. And she was like, go hang out with them. Where does your sister want to go? Ask her if she wants to go to the movies, take her to a restaurant, right? I didn't have to like throw knives at her or something to get better. So
Yeah. I was just thinking, I've had a lot of people with, like harm OCD around like driving or around just like being around cars in general. And so it might stop them from going on walks or whatnot, because they could inadvertently push someone into the street. And so it's like, well, let's just go on a walk. Like it's a nice day. Let's go on a walk and see what happens. So yeah, there's lots of things that we can do that, like you said.
yeah. Follower at 1227 asked, do you consider Boost Bar an as needed medication? Also, is taking SSRI and a TCA together common?
Great questions. Yeah. So Boost Bar, I guess my first question is for the Boost Bar, is that the primary medication? Is that an add-on medication? I think, for some people, I think Boost Bar can work. I would say in general, though, I don't find Boost Bar to be super effective. Maybe as an adjunct, and most commonly, in order for it to really help with anxiety, it is like an everyday med, and most often it needs to be at higher doses. I think sometimes I see people being prescribed Boost Bar at like 5 or 10 milligrams, and if we're using Boost Bar, which I don't love using, that's probably not going to do much. It really needs to be maybe up to 40 plus milligrams a day. But I think all that to say is, if that's the medication that someone's on, I kind of want to wonder why they aren't on a different form of medication, and that also increase serotonin. And the reason for that is because we want to make sure that we're not on too many meds that increase serotonin. So we want to be mindful of side effects and risks. But kind of going into the next question about being on an SSRI and a TCA at the same time, there are certainly that can be something that someone does, I think, but you have to be very careful in terms of what the doses are and how you're doing it. I'm guessing, since we're talking about OCD, maybe we're thinking more of clomipramine, because that's the TCA that has the most evidence base for OCD. And one thing that I actually do sometimes for individuals who are on clomipramine, because even though it can be a really great medication, it does tend to have a lot more side effects than the SSRIs. Sometimes you can add a low dose of Luvox specifically. It's one of the SSRIs. And it can really help with some of the side effects with the clomipramine. And so when I do add them together, I'm not usually adding an SSRI at an OCD dose with clomipramine, because then we could be pretty concerned about certain side effects. But if I'm adding like a low dose to sort of change the way that clomipramine is metabolized and playing around with it based on interactions with like low dose Luvox, then certainly it's something that I've done before, and it can be really helpful.
Yeah. Lewis asked at 1233, so Chris, are you saying medication and the person needs to be harmony together to get it, the best benefit from it? So what I was saying, just to clarify, Lewis, is that, and this, I want to ask you this, Jennifer. So I'll ask you the question. I'll respond to Lewis, but I want to hear your answer. What percentage typically, if someone's taking a medication alone, typically what percentage of relief could they expect? So what I was saying, Lewis, is typically if people are doing both the medication and they're doing treatment, so they're meeting with an OCD specialist, they're starting with frontline treatments, that's when I really see the magic happen. And I know the IOCDF just put out their treatment guidelines, and that's one of the things that they said, is that they frontline is either ERP medication and the combination of both. So I always tell people, there's some people not ready to do treatment. They'll start on medication and see some relief. So I'll toss it to you, Jen. If somebody takes medication alone, what kind of relief do they usually see, and why is it important to maybe add in treatment as well?
Yeah, for sure. So I think, it really depends on the severity of the OCD. For individuals, who have more mild forms of OCD, I've seen, and if someone doesn't have like the time or the ability to commit to ERP, or isn't able to engage in it for whatever reason that might be, I've certainly seen that medication alone can be helpful, and there is some. But I think once we're starting to get into more moderate, severe forms of OCD, it's so important to incorporate the ERP. And even in mild forms, sometimes I would say ERP it might even help you more than the medication. It really sort of depends. But in any case, there probably is some edge that's being taken off with some medication, but really the magic is the combination of the two.
Yeah. Somebody said they love bed rotting. I know it's Astasia, it's addicting, but I think, like I said, there's a difference between like you're burnt out from work and you don't want to see the world, and you've always wanted to catch up on like The Office, and you want, it's, I always tell, go back to like functional behavior. I'm talking about those are the five things people usually do to avoid. It's not bad, to scroll on your phone or to take a nap if you're exhausted, but I think if it's solely to avoid the OCD, definitely that. Freedom said that she is going to the Faith and OCD conference. Yes, yes, yes. There's a lot of good stuff that ISDF is putting out. So make sure you definitely do that. Somebody said, this is Chantel. She's at 1246. And then, yeah. So she says, I've been on sertraline for 10 years. I started back after giving birth to my daughter, and OCD was so ramped up. So perinatal OCD is a real thing, folks, definitely. Over the years, I've done so much work with an OCD therapist and support group. I've slowly weaned down to 50 milligrams. If I feel great, should I try to wean some more or just leave it as I'm doing great?
So that's a great question. Yeah, I think it's such a personal decision. And, based on some of the history, it might make me lean more in one or the other direction. But just based on that information alone, I don't think it's necessarily wrong to go either way. I think if you do decide to come off of it, again, going really slow is the most important thing. And if anything kind of comes back, going back to the 50 milligram dose, and because we know that that works. The other thing I really want to say is that it's interesting when we come off of SSRIs because it's actually a lot harder to go from like 50 milligrams off for Zoloft, for example, than from like 200 to 50, because the way that these medications are designed and binding to our receptors, it's like a hyperbolic curve, meaning that when you go lower and lower on the dose, you notice more and more of withdrawal. So it actually, when you get to the lower doses, you want to go slower and slower because it's harder in that last bit of time. So that's something I just want individuals to be really mindful of. If it maybe for some people, it could be not that hard to go from 100 milligrams to 50 milligrams, but it's not the same as 50 to nothing. It's actually probably more like 50 to 25 or 50 to 30 is sort of the same difference.
Yeah. Okay, I'm going to sneak in one real quick question. I know we're at time, but I think this is a great question. Mary asked at 1245 on Facebook, does Prozac lose its effectiveness over time? And then is there a difference between generic Prozac and labeled? So maybe to generalize it, one, does medication lose its effectiveness over time? And then two, is there a big difference between generic medications and name medications? She's asking specifically for Prozac, but maybe with Prozac and then in general.
Yeah. So, what I would say is, in terms of medications losing effect over time, it's really hard to answer that question. I think for a lot of people, people do really well on the same dose for several years, and it works great. Every now and then, I think there is more research in this area of looking at this. It's called like tachyphylaxis. Like as you are on something more and more, like do you need higher and higher doses to sort of get the same effect? And the answer is usually no. But at the same time, there could be, changes in life that happen and trigger certain things, or, as we know, OCD really sort of morphs and can change over time. And maybe for many years it was contamination based and we sort of got things under control, and then it shows up in a different way. And now it's more health anxiety based. And with these different triggers and different ways things pop up, it might be that there does need to be sort of a change. So it really just depends on the person. And then in terms of generic versus brand name, I would say in general, they're both are equally effective. I think for me personally, it's very rare where I would ever say like someone needs to be on a brand specific version. Every now and then I'll like see a client that has been on like a specific brand one, and they've told me that they didn't have as good of a reaction to the generic versus brand for whatever reason. And then sometimes like the way that the fillers and things like inside the medications might be a little bit different. And sometimes people have like allergies to certain fillers and they might require brand name, but in general, the generics, usually work really well. So.
All right. Well, this is the time where I'm going to give you a final thought. I'm going to give you a final thought before the final announcements. I just want to say, what I think you were able to display today, it is so important, folks, to find a psychiatrist, a prescriber that really knows OCD. As you could see, Dr. Siegel, you were flawless in your, in answering your questions. You are such just so much knowledge, right? And I think that you really displayed what the difference is with somebody who really knows it. And I can tell you on my end, it's always hard because I'll have clients come in on like 10 milligrams of Prozac for 10 years and be like, why isn't it helping? So what I hope to say is that if you're watching this and really need a prescriber, try to find somebody that has some expertise in OCD. Obviously, I know that, everybody has different resources and stuff, but if you can find someone that has had some experience with working with OCD, as you could see with Dr. Siegel, she was able to answer a lot of your questions because this is what she lives, breathes, and sleeps. So thank you. And if you want to see more of her, like I said, head over to ocdsocal.org. You'll /conference and Dr. Siegel speaking at the conference. We're an official affiliate of the International OCD Foundation. What would your final thought like to be for everybody?
Yeah, I'm just so appreciative that you had me on. I am grateful for all of those kind words, Chris. And I think it's equally true that making sure that you go to a specialist for treatment too, because there's a lot of times people say that they treat OCD and it's not necessarily with ERP. There's other modalities that people are using that are not as evidence-based. So it's so important that, you find the clinicians that are using the most evidence-based tools and support for OCD. And yeah, it was great to chat with all of you guys, and hope to see you at the OCD SoCal online conference in November.
Yes, and you're wearing my favorite color, yellow, so you're already great.
Yes.
As you can see, Rachel put up, go to iocdf.org/find-help / please find someone. That's how I found my treatment provider many years ago, and it was game-changing from the therapist that claimed they knew OCD. Before I let you go, don't forget, next week is the big OCD Awareness Week. The IOCDF is your one-stop shop for everything OCD Awareness Week. Go to iocdf.org/OCD Week. There's a calendar with events. I'm going to be back with a live stream with one of the IOCDF staff members, Stephanie, who's a good friend. She's an amazing human being. She's going to be on here to talk about the IOCDF and about OCD. And there's just so many events, in-person and virtual events. So please get involved. We also have the OCD and Faith Conference coming up. There's going to be a lot more events. It's in January, but the OCD Kids Camp. So make sure to head over and bookmark iocdf.org. We'll be back next Wednesday, like I said, for a special OCD Awareness Week live stream. And Dr. Siegel, will have you back on. Thank you so much for your time. And I hope everybody got something from this. And thanks everyone for hanging out and asking your questions. And if we didn't get your question, I put it on a document and we make sure to put those in future live streams. So tune back. But take care, Dr. Siegel. Have a great rest of your day.
Thanks,
and
you
thank
too.
You, IOCF.